to this Children's Nursing Development Unit Journal Club session. A particular warm welcome to anyone joining us for the first time. Are you watching this alone today, or have you gathered with a group of colleagues? If you are not with others today, consider gathering a group next time so that you can consider the questions provided at the end together. You may also be interested to know that you can access all our past Journal Club through our website. You can see the link here on the screen. You may find a journal article particularly of interest to you and your clinical setting. So for today, let's get going. This month's article is titled Sleep Promotion for Hospitalized Children, Developing an Evidence-Based Guideline for Nurses. It was written by Crossley et al. And published in the Journal Curationis in 2021. Sleep is vital for a lot of essential processes in a child, such as development, emotional regulation, behavior, coping, pain perception, vital sign regulation, improved immunity, as well as recovery from illness or injury. Some of the factors that negatively impact sleep in a hospitalized child is being ill, certain medications, as well as pre-existing sleep dysfunctions. Sleep is often disrupted by care that takes priority over sleep. Medications to improve poor sleep has its own disadvantages, such as daytime sedation, cost, and the added risk of medication errors. Evidence for non-pharmacological techniques to improve sleep is scarce, but with a nurse at the bedside, it can easily be implemented to improve sleep habits. A core part of nurses' role is to create a therapeutic environment, partnering with families to even extend the benefits of good sleep to the child's long-term health outcome. Therefore, the aim of the study was to develop an evidence-based practice guideline to promote sleep-friendly ward environments and routines facilitated by nurses, and in partnership with mothers to ultimately provide recommendations that will help nurses to improve hospitalized children's quantity and quality of sleep that will help with the healing process as well as overall well-being. The authors used a 6-step methodology. First, they identified existing guidelines and protocols. For appraisal, they used the agreed-to instrument. After that, an evidence base was developed. In step 4, recommendations were modified in line with the South African Nursing Council's scope of practice as well as the Nurses' Regulation on Acts of Admissions in South Africa. Then, levels of evidence and grades of recommendation were assigned. For the last step, the end-user guidance was developed as well as a flowchart to improve the guidelines uptake. Expert consultation was obtained throughout the process. Developing high-quality and rigorously developed guidelines are expensive and difficult to achieve, especially in low-middle income countries. Therefore, adapting, or contextualizing existing guidelines is a good alternative in these settings. The guideline was developed for nurses working at a tertiary institution in South Africa, which is a low-middle income country with limited resources. The scope of this guideline was defined by the Population, Concept, Context, or PCC approach to determine the inclusion and exclusion criteria. The inclusion criteria was as follows: children in pediatric wards in a low-resourced hospital in South Africa between the ages of 4 months to 13 years. This age range was selected as sleeping patterns for this group was thought to be very similar. Furthermore, any guideline that looked at non-pharmacological sleep promotion in hospital was included. Guidelines from 1 January 2010 to February 2020 were included, as well as studies in English, Afrikaans, and Dutch. Exclusion criteria included children with the primary diagnosis of sleep disorders, unstable or critically ill children, as well as outpatient and non-hospital care facilities. So let's look at what they found. 88 sources from PubMed and 2,433 sources from websites, of which 1 was a guideline and 2 articles met the inclusion criteria and underwent full text screening. Authors of the 2 articles were contacted that led to the further inclusion of an unpublished manuscript as well as the NAPTIME registered nurse checklist. The guideline was excluded after the process of development was unclear, which left the two sources for modification: Rest and Sleep for the intensive care patient by Elliott et al. And Nap Time, an overnight non-pharmacological intensive care unit sleep promotion protocol by Knart et al. The article by Elliott et al. Looked at 10 recommendations on sleep-promoting activities for adults in intensive care units in Sydney, Australia, that included aspects such as noise reduction, cycled lighting, optimizing sleep through pain control, optimizing circadian rhythm, providing daytime rest periods, ensuring optimal nighttime sleep conditions, which included cluster care, environmental interventions, and manipulation of ventilators. Whereas the Nap Time study was an overnight sleep promotion initiative created for adult patients in ICU in America. It had a two-tiered approach: organizational and patient-specific factors such as acuity, timing of care, rescheduling activities, whilst still providing unhindered emergency care where required. An unpublished document by the same author further provided the recommendation of the nurse as a gatekeeper, protecting the patient from sleep interruptions. After review, 41 eligible recommendations were refined to 6 themes: safety and other special considerations, collaboration with the bedside carer to promote individualized sleep, coordination of the ward routine, ward environment to improve sleep, collaborating and communicating with staff and other persons to protect sleep, and finally, performing a basic sleep assessment. A pediatric sleep assessment tool was found to replace the adult-based one used in the original guideline. In addition, the Regulate framework was added to help nurses to meet the children's needs for optimal rest and sleep. For a better understanding on how to apply the 6 themes, go and further explore the flowchart as it unpacks the nurse's role in non-pharmacological sleep promotion for children in hospital. It includes the 6 themes, the Regulate framework for overall care and regulation, as well as the BEADS sleep screening tool to help with the last theme, which is to assess sleep. For best results, the flowchart should be used in conjunction with the full evidence guideline, which is available from the author, as well as appropriate staff education and training. In conclusion, hospitalization challenges children's ability to regulate. Poor sleep amplifies dysregulation, which is a result of hospitalization where care is often prioritized above sleep. Nurses are often unaware of their contribution to children's sleep loss whilst in hospital. However, nurses are ideally positioned to advocate and help children sleep through engagement and partnering with families to promote health. The guideline aims to help nurses to actively engage in sleep promotion for the hospitalized child. Partnering with families represents collaborative healthcare that holds the promise of benefits that extend beyond discharge home in resource-constrained contexts. Which brings us to the end of the article, and I advise you to take a few moments to think about all that you have heard. Then turn to the reflective questions for this week. Has the article made you think differently about children's sleep or lack thereof in hospital? In what way do you think this guideline could be applicable to your clinical setting? Is there an aspect of sleep promotion that you think you could improve on? Consider what is required to implement this guideline and share how you would go about it with the rest of the group. Thank you for listening. I hope it was interesting to you and that you're excited to access the new Journal Club next month. Look out for its launch on our social media platforms. Bye for now.